Deep Dive, your shortcut to being well-informed. We take sources, dig deep, and pull out the most important nuggets of knowledge for you. Today we're embarking on a really crucial deep dive into the Academy of Breastfeeding Medicine's clinical protocol, #33. That's the one on lactation care for lesbian, gay, bisexual, transgender, queer, questioning, plus patients. If you're a practitioner dedicated to truly comprehensive and inclusive lactation care, or maybe you're prepping for something like the IBCLC exam, this is definitely for you. And this protocol, it's not just about, learning definitions. It's a critical guide. It's about affirming the diverse needs of LGBTQ plus individuals and families, specifically in the context of lactation. It really aims to tackle the widespread misunderstanding and, frankly, the very real stigma these families often face in medical interactions.
That's absolutely right. The core mission here really is to give healthcare providers concrete guidance. It acknowledges something important. Children raised by LGBTQ plus parents are healthy, they thrive, yet the parents themselves frequently encounter care that's inadequate, sometimes even harmful. So we'll be looking at the specific challenges they face and how this protocol offers kind of a roadmap for respectful, effective support.
Okay, so let's unpack this. Our mission today is to break down the key definitions, look at general considerations for creating those affirming spaces, the implications of transition-related care, fertility options, the nuances of induced lactation and co-lactation, and then wrap up with those vital hospital and NICU considerations. And like I mentioned, for those of you with that IBCLC exam goal in mind, we'll cap it off with some discussion points, thinking about case-based questions drawn right from the protocol. Understanding the foundation, language and purpose. First things first, let's lay the groundwork. The protocol kicks off by emphasizing just how critical language is. Why is this so foundational? It's more than just politeness, right?
Right. What's fascinating here is how it highlights that terminology isn't fixed. It's fluid. Often community-specific. They point to sources like the UCSF Transgender Care Guidelines and the LGBTQI plus acronym itself. It's explained as an umbrella term: lesbian, gay, bisexual, transgender, queer, questioning, and other diversities. Using respectful language, it just profoundly impacts a patient's sense of safety, their willingness to even engage with care.
Yeah, that makes sense. And when we talk about affirming care, the protocol defines it as actively supporting a patient's gender identity, using inclusive terms, having knowledgeable providers, and this brings in affirmed pronouns and name, the ones chosen by the individual. Seems simple, but powerful.
It really is. And it's crucial to get the terms right that differentiate gender identity from assigned sex at birth. So you have assigned female at birth, or AFA, assigned male at birth, AMA versus cisgender, where gender identity aligns with the birth assignment, and transgender, where it doesn't. They define gender identity as that innate sense of self, which is, distinct from sexual orientation who someone's attracted to.
The protocol also introduces other really essential terms. Things like chest feeding, which is often used by transmasculine folks, a way to talk about feeding outside those traditional gendered labels, or co-lactation, when more than one parent is breast or chest feeding. Then there's gender-affirming surgery, gender-expansive, genderqueer, non-binary, and importantly, gender incongruence. That's the current term, moving away from gender dysphoria.
Exactly. That shift to gender incongruence is significant. It moves away from pathologizing the identity itself. Instead, it focuses on the distress someone might feel when their identity doesn't align with their assigned sex. And if you connect this to the bigger picture, the protocol stresses, patients often don't disclose LGBTQ plus identities. Why? Fear of discrimination. It's a very real fear. Studies sadly show high rates of negative healthcare experiences for transgender individuals. That leads to delayed care, misdiagnoses, even, tragically, patient deaths. So you can see how affirming care, even something as basic as using correct names and pronouns, can significantly improve health outcomes. It can actually mitigate the effects of stigma, too, creating a respectful healthcare environment.
Okay, so beyond just understanding the terms, how do we operationalize this? How do we actually create an environment where patients feel safe and respected? What are the practical steps?
That's the key question for every clinician, isn't it? And the protocol gives concrete steps. For individual providers, it means never assume gender identity from appearance. Ever. Always ask for affirmed names and pronouns. And a great tip, simple but effective: introduce yourself with your pronouns. Hi, I'm Dr. Smith. I use she/her pronouns. It just normalizes it, encourages the patient to share theirs.
That seems like such a small thing, but yeah, really powerful. What about when mistakes happen? Because they will, especially when we're learning. How does the protocol say to handle misgendering?
Yeah, this is a common worry. The protocol is direct. If you unintentionally misgender someone, acknowledge it, correct it quickly, and then move on with the visit. The key is not dwelling on it. Prolonged apologies can actually shift the focus away from the patient's care and make it about your discomfort. It's about showing respect efficiently.
Right, get back to the patient's needs. And what about the bigger picture? Institutions, clinics, what can they do beyond just individual interactions?
Oh, there's a lot they can do. Critical for systemic change. Update intake forms, get beyond just binary male-female options for gender, add fields for pronouns, sexual orientation, implement gender-neutral bathrooms. That sends a clear visual message, display signs of inclusivity, and crucially, ensure patient confidentiality. Disclosing someone's identity without consent can compromise their safety outside the clinic walls. The protocol also suggests avoiding gendered terms in clinic names, so think parent education, not mom's group, prenatal care, not women's health. Also, display affirmed names, not just legal names, on things like hospital wristbands, and avoid gendered prefixes like Mr. and Mrs. If you don't know someone's gender, just use their first and last name. 3. Effects of transition-related healthcare on pregnancy and breast chest feeding.
Okay, this is where it gets really, really interesting for those of us focused on lactation. How do different gender-affirming treatments actually impact fertility, pregnancy, and the ability to breast or chest feed? It's pretty complex.
It truly is, and it's an area with significant clinical considerations. Take adolescence, for instance. Pubertal suppression using GnRHA therapy, that's a hormone treatment that pauses puberty. It halts secondary sex characteristics, but it also prevents the maturation of eggs and sperm precursors, so oocytes and spermatogonia. This brings up real challenges for fertility preservation down the line. The protocol highlights that delaying surgeries, like top surgery for trans men, might prolong gender dysphoria, yet we actually lack solid data on how postpubertal hormone therapy affects fertility long-term. So the crucial takeaway, the clinical pearl here, is that fertility preservation options banking sperm or eggs should always be discussed before starting these therapies.
Got it. What about feminizing hormone therapy for trans women? How does that impact their potential for lactation?
Right. Feminizing treatments, usually estrogen and anti-androgens, they do induce breast tissue development. There's at least one documented case report and quite a few anecdotal reports of trans women successfully inducing lactation producing human milk. However, something to keep in mind, breast augmentation surgery can sometimes mask underlying inadequate mammary tissue development, or it might even increase the risk of engorgement.
Okay. And for masculinizing treatments, like testosterone therapy, especially for trans men who become gestational parents.
Testosterone works by suppressing the body's own estrogen, and this can cause atrophy, a shrinking, of estrogen-responsive breast tissues. Trans men who decide to carry a pregnancy usually pause their testosterone during pregnancy. They might also continue to pause it postpartum if they want to lactate. Also need to consider chest binding. While it can be really affirming, if used during lactation, it could potentially cause compression atrophy, worsen engorgement, or even lower milk supply. And top surgery, that significantly impacts lactation potential. It really depends heavily on the surgical technique used, specifically how well the nipple areolar complex, the NAC, and the underlying milk ducts were preserved. Cosmetic tattooing of the NAC, while visually affirming, doesn't mean there's functional lactation potential.
So beyond the physical aspects, what about the emotional side? The impact of these hormonal shifts or surgical changes during pregnancy and lactation?
That's such a critical point the protocol emphasizes. There's a significant risk of increased gender dysphoria for trans patients. This can happen because of the hormonal changes of pregnancy itself, or from suspending their gender-affirming hormones. So being sensitive here means truly supporting their decisions, supporting their choice to resume gender-affirming treatments after birth, and crucially, also supporting decisions not to lactate if that's what feels right for their mental health and gender affirmation. 4. Fertility options, induced lactation, and co-lactation.
Okay, moving beyond the specific effects of transition, what are the broader fertility options for LGBTQ plus individuals? And how does this protocol guide the processes of induced lactation and co-lactation?
Fertility goals vary so widely in the LGBTQ plus community. So the first rule is avoid assumptions. Options can range from surrogacy or adoption if neither partner can carry a child. If at least one partner can carry a child, then options include penetrative intercourse, IUI, intrauterine insemination, IVF, in vitro fertilization, using donor sperm or donor eggs. Providers really need to be informed about local resources and, unfortunately, sometimes legal restrictions that might apply in their area.
Got it. Now let's get into a central and frankly fascinating part of this protocol, induced lactation. What does that process actually involve for someone who hasn't been pregnant, like a non-gestational parent or a trans individual?
Right. Inducing lactation means starting milk production without having gone through a pregnancy. You can think of it as roughly a 3-stage process, aiming to mimic how the body normally prepares. The protocol outlines these general components. First, hormonal priming. This usually involves taking a combined oral contraceptive estrogen and progesterone continuously for about 3 to 6 months. This mimics pregnancy hormones. Doses might gradually increase, but providers absolutely must discuss the risks, like blood clots associated with higher estrogen doses. Gentle nipple and areola stimulation is also recommended during this phase. Second stage, prolactin promotion. This is often done using galactagogues medications that boost prolactin levels. Domperidone has the strongest evidence according to the protocol, but it's important to remember it's not FDA approved in the US, so alternatives like metoclopramide or certain herbal galactagogues might be tried. And third, expression. About a month before the planned feeding start date, those high doses of estrogen and progesterone are stopped. Then consistent hand expression and pumping begins. Gradually increasing frequency and duration, aiming for maybe 5-10 minutes, 6-8 times a day. Getting the right flange fit. Getting proper pump instruction from a trained professional, that's absolutely crucial for success and comfort. Using lubricants like lanolin or coconut oil can also help reduce discomfort during pumping.
Okay, that's a detailed process. And for families considering colactation, where more than one parent feeds the child, what are the key discussions that need to happen? I know there's a common misconception about this.
Yes, absolutely. It's so important to discuss expectations and goals really openly. The protocol specifically states, and this is the misconception you mentioned, that colactation is unlikely to decrease the workload for the gestational parent. If anything, it might add to it, at least initially, with managing multiple milk supplies. So families should collaboratively discuss other duties, identify support resources, decide who will do skin-to-skin right after birth, who will initiate feeding, and make a plan for how multiple milk supplies will be established and maintained. Appendix A1 in the protocol actually offers a sample colactation plan, which is incredibly helpful for families. And remember, all lactating parents, whether gestational or not, need frequent milk removal to maintain supply. Galactagogues might be needed. And prioritizing colostrum feeding by the gestational parent right after birth is key. Hospital and NICU considerations.
This protocol really gets into the nitty-gritty, even covering scenarios like adoption or surrogacy. What special considerations come up for these families, especially when they're navigating care in the hospital and particularly the NICU?
Right. For adoption or surrogacy, especially if the birth happens in an unfamiliar hospital, the lactation consultant can be a crucial bridge, a mediator helping with communication and continuity. Before the birth, the protocol recommends considering testing for transmissible infections, things like HIV, syphilis, Hep B, Hep C, TB, CMV, HTLV-3 for the non-gestational parent who plans to provide milk. It's also important to examine their breasts or chest for any active herpes lesions and counsel them not to feed during an outbreak. And with the patient's consent, contacting the birth hospital's lactation team beforehand can smooth the way, ensuring accurate pronoun and name use, discussing the feeding plan ahead of time.
What about the birth experience itself for LGBTQ+ parents? What unique challenges might they encounter in the hospital setting?
Yeah, birth facilities aren't always set up or prepared for gender and sexual diversity, and sadly, families might arrive with a history of discrimination, feeling understandably wary. So the lactation support team has this unique opportunity to be prepared, to be informed, and just offer genuine kindness. Standard care to promote human milk feeding, prenatal ed, immediate skin-to-skin, rooming in, feeding on demand that should always be provided. However, the guidance around exclusive breastfeeding might need adjustment. Full milk production often isn't achievable with induced lactation or after certain types of top surgery. So parents should be encouraged to provide as much human milk as they can and be educated on safe supplementation options if needed.
And if multiple family members are planning to breast or chest feed, how does the hospital environment support that?
They really need to co-create a feeding plan. Decide beforehand who does the first skin-to-skin, who initiates feeding. All lactating parents' medications and health conditions need careful review by the medical team. Privacy is often a major concern, maybe due to body dysphoria, surgical scars, or past trauma histories. So respecting privacy during exams, during latch assistance, maybe offering a hands-off approach if that's preferred is really paramount. Latch itself can have specific considerations for trans individuals. You might be working with less flexible chest or areolar tissue. Nipple shields might be helpful. Positioning might need adjustment, especially after top surgery where there's no natural breast droop or pendulousness. And for low supply, using a supplemental feeding tube right at the breast or chest can be a great tool. It provides nutrition while still stimulating milk transfer and the parent-infant bond.
The NICU setting sounds even more complex, just given the sheer number of staff involved, often rotating.
Absolutely. The protocol specifically notes that the large, frequently changing staff in NICUs makes consistent, inclusive language harder to maintain. This is where things like inclusive intake forms become vital, using terms like parent 1, parent 2 instead of mother, father. Leadership really has to emphasize inclusive language training and ensure clear handoffs between caregivers. So families aren't constantly burdened with re-educating staff or repeatedly disclosing personal information. And critically, all parents must be included in medical decision-making for their child.
What about milk sources when parents can't produce enough? This can be a real source of stress for families.
Yeah, it is. Donor human milk is often the ideal alternative, but it's frequently unavailable or prohibitively expensive. This leads many LGBTQ plus families toward informal milk-sharing communities. Now, the American Academy of Pediatrics, the AAP, doesn't endorse informal sharing, mainly because it's hard to assess the risks involved. The ABM protocol, however, takes a slightly different approach. It acknowledges both the risks and the potential benefits. It suggests steps like medical screening of the donor, if possible, and emphasizing safe milk handling practices to maximize safety if families choose this route. But both organizations strongly advise against internet-based milk sharing just because of the lack of oversight and increased potential risks. 6. Resources and future research.
It sounds like this protocol is a fantastic resource offering so much guidance. But beyond the protocol itself, what other resources are out there for families and providers? And where does future research really need to focus to fill the knowledge gaps?
Yeah, resources are growing, though still somewhat limited. The protocol mentions specific written resources like Trevor McDonald's book, Where's the Mother? Stories from a Transgender Dad. It also points to online supports Facebook groups, social media communities, and professional organizations like WPATH, World Professional Association for Transgender Health, and Lactation League International. Peer support groups are highlighted as really crucial because trans parents and LGBTQ plus families can often feel isolated in more traditional parenting spaces.
And where are the biggest gaps in our knowledge that the protocol calls out? Where should research head next?
The protocol is very explicit about significant research gaps. It strongly recommends that future research shouldn't just lump all sexual orientations and gender identities together into one LGBTQ plus category. Instead, it needs to examine subgroups to understand their unique needs and experiences. We definitely need much more investigation into milk production outcomes for parents who've had gender-affirming surgeries and for those who've induced lactation. The current data is really sparse, and given the history of neglect and discrimination these communities have faced, the protocol strongly suggests using community-based participatory research methods and qualitative studies. Let the research questions and process be guided by the community itself.
All right, let's shift gears a bit. For those of you tuning in who might be preparing for your IBCLC exam, this protocol is truly a goldmine for understanding comprehensive, inclusive lactation care. Let's think through how some of these concepts might actually appear in those case-based questions. We'll outline maybe 10 key discussion points for the protocol that could easily form the basis of exam questions and talk about how you might approach them.
Exactly. These aren't the literal questions, obviously, but they represent the core teaching points and scenarios you'd really need to understand deeply. Think of it like a quick strategy session for each key concept.
Perfect. Let's dive in. First one, scenario, patient introductions and pronouns. Mini case idea. You're meeting a new patient. Their legal name on the chart is traditionally masculine, but you're unsure of their gender identity or pronouns. What's the first step?
Okay, so the exam might test your initial interaction skills for affirming care. The best practice here. Introduce yourself with your pronouns first. Hi, I'm Sarah. I use she, her pronouns. What name and pronouns do you use? And if you slip up later, a quick, sincere, my apologies, I meant they, and then move right back to the clinical discussion. Shows respect without making it awkward.
Good point. Okay, second one. Scenario. Clinic environment inclusivity. Mini case. Your clinic's intake forms only offer male or female, and all the bathrooms are gendered. A patient expresses discomfort.
Right. This tests your ability to see the bigger picture, the systemic issues. Your knowledge should focus on practical steps. Advocating for updated intake forms, digital ones are great for this with multiple gender options, write-in fields for pronouns, suggesting gender-neutral single-stall restrooms, reviewing all clinic materials, signage, group names, parents group instead of moms group.
Makes sense.
Yeah.
Number 3, scenario. Trans man and lactation after top surgery. Mini case. A trans man who had top surgery a year ago wants to chest feed their upcoming baby, but is worried about milk production.
An exam question here would likely probe your understanding of how surgery impacts function. Key knowledge. how different surgical techniques affect the nipple areolar complex, NAC, and underlying ductal tissue. Was it a free nipple graft or a pedicle technique? Remember, cosmetic nipple tattooing doesn't mean functional nerves or ducts are intact. So you need to assess based on surgical history and physical exam, not just appearance.
Okay, number 4. Scenario. Hormonal priming for induced lactation. Mini case. A non-gestational parent wants to induce lactation. You need to explain the first phase of hormonal preparation.
The exam will check if you know the protocol's outlined steps. So you'd emphasize the long-term, continuous use of combined oral contraceptives, typically 3 to 6 months, to mimic pregnancy hormones. Mention the gradual dose increase potentially, and critically, the discussion about risks, especially blood clots with estrogen.
Got it. Number 5. Scenario. Prolactin promotion-induced lactation. Mini case. Your patient finished the hormonal priming phase. Now, what medications are typically considered to actually stimulate milk production?
This tests your knowledge of galactagogues. You'd highlight domperidone as having the strongest evidence-based mention in the protocol, but immediately add the crucial context. It's not FDA approved in the US, and access is restricted. Then you'd mention alternatives like metoclopramide or perhaps herbal options, always emphasizing informed consent and discussing potential side effects for any option.
Perfect. Number 6. Scenario. Co-lactation expectations. Mini case. A couple, gestational parent and partner, are excited about co-lactation. They think it will cut the gestational parent's feeding workload in half.
Ah, the classic misconception. The exam might present this. Your answer needs to gently correct this assumption. Clarify that co-lactation is unlikely to significantly decrease the gestational parent's workload, especially early on. The focus should shift to realistic goal setting, planning how to manage 2 milk supplies, and discussing how the non-lactating partner can support in other ways: diaper changes, burping, emotional support.
Good clarification. Okay, 7. Scenario. Pre-birth planning for non-gestational lactating parent. Mini case. A non-gestational parent plans to induce lactation and provide milk. They ask if they need any specific medical tests beforehand.
This highlights crucial safety protocols. You need to recall the recommended screenings for transmissible infections mentioned in the protocol: HIV, Hep B, Hep C, syphilis, TB, CMV, HTLV-3. Explain why these are important. It's about ensuring the safety of the milk for the infant, similar to screening for donut milk.
Makes sense. Number 8. Scenario. Latch challenges with a transparent. Mini case. You're helping a transparent latch their baby. They had top surgery with free nipple grafts, and the chest tissue is firm, not very flexible, making latch difficult.
This tests your problem-solving skills for unique anatomies. Think about solutions. Could a nipple shield help create a better latch point? Experimenting with different positions, maybe a higher hold like the football hold. Also, consider if a supplemental nursing system, SNS, at the chest might be useful if supply is low or latch is tricky, to ensure baby gets nutrition while still stimulating the parent's body.
Good practical tips. Number 9. Scenario. Supporting gender dysphoria during lactation. Mini case. A trans parent mentions feeling increased gender dysphoria due to the physical changes of lactation and having paused their testosterone. They're unsure about continuing lactation.
An exam question here really gauges your sensitivity and ethical care approach. The key is validating their feelings. Acknowledge the known risk of heightened dysphoria in this situation. Your response should emphasize supporting their decision-making process regarding lactation duration. That includes supporting the choice to stop lactating if needed for their well-being, and supporting their plan to resume gender-affirming hormones when they feel ready.
Crucial point. Okay, last one, number 10. Scenario. Informal milk sharing guidance. Mini case. A family can't access donor human milk and asks about getting milk from a friend or online group. What guidance do you provide?
This probes your understanding of the nuances between different professional guidelines. You'd contrast the AAP stance, which doesn't endorse informal sharing due to risk assessment difficulties, with the ABM's position in this protocol. ABM acknowledges the reality, the risks and benefits, and suggests harm reduction strategies like medical screening of the donor, if possible, and safe milk handling. But you absolutely must mention that both organizations strongly advise against internet-based sharing due to the lack of control and safety concerns.
Wow, okay, that was a truly comprehensive deep dive into ABM protocol, #33. It covers so much ground, from the real subtleties of inclusive language and creating affirming spaces, all the way to the practical complexities of induced lactation, co-lactation, and navigating those tricky hospital and ICU scenarios. There's just so much valuable information here for lactation care providers.
It really does push us, doesn't it, to think beyond the sort of traditional frameworks and really recognize the unique needs, the unique experiences of LGBTQ plus families. And understanding and applying this knowledge, it's not just about, passing an exam, although that's important for many. It's fundamentally about providing compassionate, evidence-informed care that truly supports every family trying to nourish their child.
So what does this all mean for you, our listeners? Whether you're deep in study mode for the IBCLC or simply committed to improving your patient care day to day, how can you take these insights and actively apply them? How can you help create more welcoming, more affirming spaces, whether that's in your clinical practice and how you collaborate with colleagues, or even just how you engage within your wider community? It feels like a really powerful journey towards broader understanding and truly inclusive care for everyone.
Absolutely. And it's important to remember there's always more to learn. This protocol #33, it's a fantastic starting point, a foundation for critical thinking and continued professional growth in this really essential area of healthcare.
Well, thank you for diving deep with us today. We really hope this has given you a useful shortcut to being well informed on this vital topic and maybe inspired you to keep exploring and learning.